Hello, everybody. As we all know, that oral cavity is the mirror for the whole body system, and oral cavity actually plays a gateway for the systemic health of any individual. So today's presentation is a brief, a brief emphasis laying on the interdepartmental or medical as well as dental fraternity collaboration and the importance of the systemic diseases such as gastroesophageal reflux disease, leaving some clues in the oral cavity, and how we as dentists can be sometimes one of the first clinicians to identify the systemic hidden condition into the gastric region. So it would be a brief presentation in the interdepartmental collaboration, and the emphasis is given to the well-being of the patient as a whole. So this is Dr. Gausia, and this is my brief introduction. I'm a pediatric dentist, and these are my additional qualifications wherein I specialize into special needs children's taking care and also palliative care. So moving on to the condition gastroesophageal reflux disease, less spoken on in infants and children, but it does exist, and we do see it as refusal to feeds, refusal to food once the child grows. Now, in the initial stages of infancy, when the child is refusing to take a feed in, that is probably because of the misdiagnosed condition of an acid reflux, which has been missed by the pediatrician or even the parent itself. Eventually, the feed refusals would lead to the oromotor sensory issues, unfortunately, because the senses required for suck swallow breathing, the initial oromotor mechanism, which is a prime criteria for child's development, is being somewhere affected. So these sensory issues, the senses are the signals which would initiate the motor activation of the child. More so, the oral cavity being the most prime important regulatory system of the whole body system in the initial part of the life itself. So the unidentified or a silent hidden condition like GERD in a small infant can go a long way in the developing of the unfortunate incidences of oromotor issues. So oromotor sensory issues, the child may not get the sense of taste, texture, quality, shape, temperature, and eventually the motor mechanism is not enough stimulated uh, and enough grown, and eventually the child, as the child grows into the toddler stage, would would give us witnesses of oral aversion, food refusals, also leading to toothbrush refusal or toothpaste using refusals, and further leading to conditions like food pocketing or accumulation of food into the cheeks, otherwise called as food pouching, leading to early childhood caries in very early ages, and very poor oral hygiene conditions, also leading to conditions like picky eating and neophobia. So it is very important for a clinician to identify if there is a hidden diagnosis of GERD in early stages of infancy in childhood. Now, moving on further uh, to the condition, to understand further, as the Montreal definition or the classification given by the gastroenterology department in 2006, which is followed till date with few modifications. I would like to emphasize, and the scope of today's talk would be only to the extra esophageal or supraesophageal syndromes, and primarily to the concerned topic, that is the reflux dental erosions. As you can see, me being a dentist, I would focus only on this condition. Now, dental erosions is something which occurs gradually over a period of long years. That is the detrimental effect or a degeneration of the enamel structure of the tooth. So further moving on, into 2017, the gastroenterology department comes up with a few more symptoms of GERD patients in the oral cavity. They include the soft tissues as well as the hard tissue. Nevertheless, the soft tissue symptoms are still not inculcated in the Montreal classification of extraesophageal syndrome. Montreal classification of 2006 still sticks to the dental erosion, that is the hard substance system. But since the findings are quite prominent and also noteworthy, it is important that we have a brief idea of soft tissue conditions of the GERD patients as well. So we can notice that there is reduced salivary flow in these patients. Also, the swallowing function is affected. and leading to as oral infections, and further going on to some conditions like gingivitis, inflammation of oral mucosal regions leading to ulcerations, burning sensation of the soft tissues, and in mechanical stimulus you see bruxism eventually. Of course, for the hard tissues, which will be laboratorily speaking, and it's more prominent in GERD patient, that is the dental erosion. Also to keep in mind, dental erosion is an irreversible condition. So that's why it becomes more important for us to diagnose it at an early stage, find out the etiology of this condition. We as dental clinicians should be in a position to find out the underlying etiology if there is no bacterial origin like caries present into the individual. So, as we all know already, that one of the most hardest substance in the body, more harder than the bone, is of that of the tooth enamel. Now, tooth enamel is supposed to be stronger, hardest as hard as that of the steel. If you compare the Mohs hardness scale, which is one standard scale for hardness, the diamond falls at the rating of 10, and tooth enamel is somewhere at the level of 5. So, to understand further the structure of enamel, which is built up of hydroxyapatite crystals, the enamel rods. Now, enamel rods are keyhole shaped or paddle shaped. They're closely knitted in structures, and on the SEM, that is the scanning electron microscope structure, if you analyze, it looks like a fishy scale structure. And to understand further, that enamel is made up of 96% of minerals and 4% of water only. Now, what is the fact that this enamel is such a strong material that it can withstand the masticated forces as much as, that is 770 Newton, which is equal to 78 kilograms. Now, what could be the reason for it to lead to detrimentation? Like bacterial origin, we do see dental caries causing its causing its deterioration or demineralization, and the non-bacterial origin could be that of the acidic origin, which is from the acidic reflux or the GERD disease in an individual. To understand that the deterioration of enamel, such a hard substance such as enamel, we need to first understand the critical pH which causes the enamel demineralization. Furthermore, we should understand that the actual pH of our oral cavity of an every individual is of a healthy individual is ranging between 6.2 to 7, and that of the toothpaste is 9, which is actually enhancing our critical pH and the freshness or the remineralization of our enamel and dentin is there. Now, the critical pH for any enamel structure to deteriorate is standardized to 5.5, but this is not a constant factor. Even the critical pH can range from as low as 4.5 to 5.5, depending on the quality of the saliva or the mineral content of the saliva of an individual. If there are any comorbidities, of course, the salivary content or the salivary minerals are affected of an individual. So even a pH of less than 4.5 can also cause demineralization or the deterioration of the enamel structure, leading to its cavitation. So this is of the bacterial origin. The non-bacterial origin, which we can think of the enamel deterioration, would be that of the gastrointestinal pH. Now, we all know the gastrointestinal pH is something ranging between 1.2 to 2, and most of the gastric content is that of the which is of hydrochloric acid. Now, we can imagine the kind of deterioration or the detrimental effect the gastrointestinal fluid can have on the enamel structure of our oral cavity. So that is the reason we could see so many hard tissue findings. So to understand in detail further again the tooth erosion we should understand can be endogenous origin or an exogenous origin. Now, endogenous origin is basically our gastric reflux or the acid reflux caused from the GERD disease. Exogenous types is further acidic environment from the outside, external beverages or any of the citric fruits. So what are the this leads to it's very prominent that tooth erosion leading from the endogenous is basically on the palatal side of the upper incisors, as seen in the picture here. Only if extreme cases of endogenous origin can touch the labial surfaces, wherein you see the translucent enamel is being exposed in the other picture. The labial surface only when additional endogenous and exogenous surfaces are seen. So that was the upper arch. Lower arches in the cusps and the molars, you see the cupping, the pivoting of the cusps, and also in the next picture you see the whole arch getting affected, and also the deterioration. The dentin reaches the roots, and even the roots are getting deteriorated with some of the soft tissue destruction as well. So they are called as GERD teeth, which is after the resultant of acidic events. Now, irrespective of how many times you're restoring or preventing, protecting it from the glass INMF restorative cement or the dental ceramics, eventually they're all made of glass materials. So the acidic environment may not be in compatibility with the biomimetic materials which we use, and therefore leading to displaced restorations and further regression of the enamel and dentin protective layer, and if in radiographic features, sometimes even exposure of wanting to know the pulp therapy. So it is very important and very critical to protect and find out the etiology of these conditions and refer to the concerned specialist, be it a gastroenterologist or the dietitian and physician respectively, so that the etiology is addressed on prompt. Now, these are a few of the clinical pictures of the soft tissue findings. That is the erythema of the palate, soft palate gingivitis, then extreme periodontitis, ulcerations, and sometimes burning mouth. The furthermore findings are the metallic tastes because of the regurgitated bile, undigested food, then bad breath or halitosis, and burning mouth syndrome, ulcers, dry mouth because of the buffer, because the saliva loses its buffering capacity, leading to decreased salivation and eventually dry mouth. Now, there are evidences that GERD can also cause temporomandibular joint disorders, and most of the temporomandibular joint disorders are actually prevalent 3 times more than in non-GERD patients. And probably this could be because of the bruxism, the abnormal clenching of the teeth, because of the jagged borders or the sharp edges, which are the resultant of the cupping or the smoothened surfaces of the dental or the teeth eroded teeth. The eroded teeth are silky, glazed structures, shiny, and they do not have the cuspal entanglement, eventually leading to the trigger points in the masseter tenderness and probably temporomandibular joint dysfunctions as well. There's disturbed sleep in the patients with gastroesophageal refluxes, causing to rapid eye movement sleep and leading to bruxism in the night, nocturnal bruxism, and that could be another reason for TMJ dysfunctions as well. Now, there's another interesting case report available in the literature wherein the dentist becomes one of the first clinicians to actually identify the underlying cause of GERD in a patient. This is a report about a lady aged 40 years who's been seeing a lot of physicians for her pain in the temporal and occipital regions, and finally sent to a dentist, and wherein the trigger factors in the masseter were identified, so that TMJ, probably because of the dysfunctional masticatory forces, the TMJ splint was given for nocturnal bruxism, and the dentist finds out the tintion materials in the splint because of the regurgitated bile juice. So you see the green coloring agent in the splint, wherein the dentist actually presumes that it could be because of the regurgitated bile or acid reflux, and finally refers the patient to the gastroenterologist, and then the patient is confirmed post pH metry and endoscopy that that was a patient of a GERD patient. So that is the vital role a dentist can play with prompt practices. And you see the clinical picture wherein the dental erosions were not so prominent, probably because the tooth was protected with the occlusal splints in the night. So the patient could manage to, keep some part of tooth structure saved. Now, how do we prevent this condition? These conditions can be prevented by drinking acidic liquids, and also rinsing mouth immediately with water, with even milk after an acidic event, and refraining from brushing immediately after acidic event, because it can further erode your enamel. And probably you can even rinse the mouth with an alkaline baking soda. Keep your oral cavity in an alkaline condition. And in the initial stages, maybe remineralization pastes can help, but once the glossy structure or loss of luster happens on the tooth, because there's no matrix on the enamel structure, so you need matrix for the hydroxyapatite crystals to act and remineralize the enamel. Unfortunately, in a tooth which is into erosion, uh, if a dentist can catch the lesions initially in the chalky white appearances before they can become glossy and the crystalline structure, the metric system is lost, remineralization agents, oral moisturizers can be of help. So this presentation, I hope, triggers or emphasizes that a dental professional should be acting as a prompt oral physician to find out the underlying causes of actual findings, the hard and soft tissue findings into the oral cavity, which could be, hidden clues to an underlying grave situation such as gastroesophageal reflux disease, and then has to collaborate with their medical fraternity and do the needful immediately so that the patient is given the utmost importance and gains the advantage of the prompt diagnosis. Thank you.